Okay, talking about the urinary system. A lot less organs to talk about in this lecture than what we've talked about here in our last few lectures, especially like the digestive system, which had a whole bunch of organs. We've only really got 6 organs to talk about: 2 kidneys, 2 ureters, a bladder, and a urethra. And of those 6 organs, we're going to spend the majority of the lecture talking about the kidneys. The kidneys are kind of where the magic happens, and by that I mean most of what's taking place within the urinary system. The ureters, the bladder, the urethra are really just tubes or sacs to hold or transport that urine. Okay, so really the complicated stuff takes place in our kidneys. We can kind of break down their basic purposes into kind of 2 categories: maintaining homeostasis by ridding the body of wastes, recycling necessary elements, meaning that we put those things back in the blood and don't end up pushing them out in urine, but getting out the things that we need to that are toxic to us, things like urea and creatinine and whatnot that I talk about in phys, but not in this class. Also involved with non-waste elimination and recycling processes, like maintaining blood volume, where volume refers to the amount of blood that we have. And if we think back to our lecture, when we learned about the blood, we learned about half of our blood is water. So by controlling how much water we lose in our urine or push out in our urine, we affect our blood volume. Okay? That's a way to maintain blood pressure because any increase in blood volume is going to increase blood pressure, or any decrease in blood volume decreases blood pressure. But your kidneys also release a chemical called renin that activates a really complicated series of events that all are geared towards raising blood pressure. So there's kind of a couple different ways that your kidneys help maintain blood pressure, help maintain normal blood composition. When I say composition, I mean what's in the blood. So like keeping the amount of ions in there correct and the amount of glucose and that kind of stuff dissolved in our blood plasma. Our kidneys help maintain normal body and blood pH, something very, very important. And then 2 hormones are involved with the kidneys: calcitriol, which is going to help maintain calcium levels in our blood. We didn't really talk about that one in this class, nor did we talk about this one, erythropoietin, which is a hormone that actually synthesizes or triggers the synthesis of our red blood cells. So involved with those things. Ureters are the tubes that carry the urine that's formed in our kidneys down to the bladder, which then stores the urine and wastes until it's a convenient time for disposal. So the bladder is just essentially a sac that holds that urine until it's time to pee it out, in which the urethra is going to perform that, which just discharges the urine from the bladder to the outside of the body. Now, looking at the figure here at the bottom, just kind of identifying the 6 organs. You got the right kidney, right ureter, the bladder, the left kidney, the left ureter, and then the urethra. I guess I missed that. Really not a whole lot to really identify here, but I do guess, everything's visible. So go ahead and highlight, the things that are already capitalized for you, the 6 organs, the 4 here on this side, the 2 over here on the left side of the body, that is, right side of the image. We'll also be talking about things like the renal arteries and renal veins, although, I'm not going to worry about you highlighting them here. We've talked about the adrenal glands before that sit on top of our kidneys. In our next lecture, we're going to talk about the uterus and the ovaries, fallopian tubes. This happens to be a female because males don't have ovaries and a uterus. And this will be, at least the last slide of the lecture, will be really kind of a transition from similarities between men and women. Kind of one of the first times we really talk about things that are different between men and women, aside from, just size. We've talked a lot about how, men have bigger muscles, bigger bones, bigger organs. Okay, but here we're going to see some distinctive, really big differences. And one of those involves the urethra in women compared to men. We'll get to that here towards the end of the lecture. First, we have to talk about the kidneys. And we'll spend, like I said, the majority of the lecture talking about them. Anytime you see the word renal, as you see here a lot on this slide, Renal is a just fancy word for kidney, or relates to kidneys. Renal fascia, renal cortex, renal parenchyma, it's all over the place on this page. Okay, let's read through. The paired kidneys are described as reddish, kidney bean-shaped organs located just above our waist. Considered to be retroperitoneal, which, think back to our lecture on the digestive system. We talked about the peritoneum and how some organs are located behind it. Kidneys are an example of that because, as it says, positions posterior to the peritoneum of our abdominal cavity. They lie to the left and right, the right and left, as it says, the spinal column, protected by the 11th and the 12th ribs. But that's really kind of just the upper parts of your kidneys. The majority of your kidneys just hang down below the ribs because these are your last two ribs. And so there's no muscle, there's no bone that protects the majority of the kidney. So we have to rely on our thick back muscles, like the latissimus dorsi muscles. Although they're nice and thick and protective, the kidneys are very susceptible to damage if you have like a direct blow to the lower back. In fact, if you follow MMA or boxing, they always call a hit to the lower back a kidney punch, and it can be very dangerous to the kidneys. If I go back to this previous page, probably didn't notice it at the time, but the right kidney, you can see, sits a little bit lower than the left kidney. And this relates to that big liver organ that we talked about previously that occupies the majority of kind of the upper right part of our abdomen. So it's not a huge, difference between the two sides, but the right kidney does sit a little bit lower than the left. Size-wise, they're about 12 centimeters, 10 to 12 centimeters, 4 to 5 inches in length, 5 to 7 centimeters, 2 to 3 inches wide, 3 centimeters, or a little over an inch in thickness. They weigh about 4.5 to 5 ounces, so they're pretty small and don't weigh a whole lot. At the bottom of the page, we can see one of these three layers that surrounds the kidneys to protect them. The only one that's visible is the innermost, what we call the renal capsule, shown here kind of this dark brown. Over here, we have a cadaver kidney, essentially showing you the same thing as what's over here. The renal capsule is, like I said, the innermost. It's a fibrous membrane of dense, irregular connective tissue, continuous with the outer coat of our ureters, and functions as a barrier against trauma, but also helps maintain the shape of our kidneys. Okay, directly outside of it, or superficial to it, is the adipose capsule, and as we should know by now, anytime you see the word adipose, it's indication we're talking about fat. So this is a layer of fatty tissue that surrounds that renal capsule and protects the kidneys from trauma, but also holds it in place within the abdominal cavity. So it's kind of a cushiony capsule. And then the outermost, the superficialmost, is the renal fascia, made up of dense, irregular connective tissue, helping to anchor the kidneys as well as those adrenal glands to surrounding structures and the abdominal wall. Okay. Now down here at the bottom, we've got in both of our pictures kidney that's been sectioned open. So essentially, we've removed the front of the kidney off to show what we call the renal parenchyma. The word parenchyma we've seen a couple different times. In the case of the kidneys, it's just the glandular tissue that forms the urine and is divided into two zones. And I really like the fact that they've color-coded it. The outer renal cortex here is shown kind of in the light tannish color, and the kind of darker brown is shown for the renal medulla. Okay, and we've learned the words cortex and medulla all the way back at the beginning of the semester mean, in the case of cortex or cortical, the outer part of an organ. Medulla or medullary always refers to the inner part of an organ. Now, if we kind of look really nicely here, we see the dark brownish areas in the middle are not continuous throughout the entire middle part of the kidney. There are these extensions of the renal cortex, the kind of light tan here that project between these kind of triangular shaped regions, these are called renal columns, okay? And they create what we call renal pyramids, okay? A pyramid has a triangular shape. Each of these little segments is a triangular shaped, what we call renal pyramid, okay? So there's usually about 6 to 10 of them. And if you break down the kidney into lobes, you would call that a renal lobe, which consists of the renal pyramid of one renal pyramid, the overlying area of renal cortex, and one half of each adjacent renal column. So looking at the picture, they've got it bracketed off here with this line to show this is one renal lobe. So once again, it includes one pyramid, a half of a column on one side, a half of a column on the other side, and then all of the cortex on the outside of it. And so since there's 6 to 10 of those pyramids, we could say there's 6 to 10 of those renal lobes. Now within both the cortex and the medulla are tiny little filtering structures called nephrons. Now they're microscopic. We show them here in the picture, but you would never be able to identify them like in a picture like this from the cadaver, because you'd have to zoom in with a microscope to see them. Okay. Each kidney contains about 1 million of these guys, and these are very important because they are what filter our blood and form our urine, and then drain that urine in a very specific pattern from the renal pyramids. Okay. Each renal pyramid is joined to a cup called a minor calyx, which we can see here is connected to each one of these renal pyramids. One of these is labeled a minor calyx. If there were 3 labeled, we would call them calyces. Those converge together and form a major calyx, and then several major calyxes form what's called the renal pelvis. Okay. The renal pelvis is just a continuation of a ureter that drains urine down to the urinary bladder. And that renal pelvis extends into the ureter and leaves the kidney at this indented portion of the kidney, what we call the renal hilum, or hilum as it's just labeled up here, just an indentation near the center of the concave border where the kidney receives renal nerves, blood vessels, that would be the renal artery, renal vein that you can see labeled here, the lymphatic vessels, and the ureter. We've seen, other organs have hilum. We learned that like the lungs have a hilum. That's the indented portion where, the primary bronchi came in. We talked about the hilum of lymph nodes not too long ago. Okay. Our hilum expands into a cavity within our kidney called the renal sinus. So the space here, it's just kind of covered up with all those different ducts is the sinus. Okay. It's pretty cool because, what you see over here, we can see really nicely over here on the right side of the page with our cadaver kidney. But as always, I rarely ever want you to kind of focus on the real deal. This is kind of tougher to tell things apart. This is the image that I want you to know. And I would say just looking at it, everything would be fair game for the exam. Very important image. A lot that you can see. All right, let's talk about blood flow to and from our kidneys. Something that's very prominent, especially at rest, like you guys are all in a state of right now. Okay, although our kidneys account for only 0.4% of our overall body weight, they receive about 21% of our blood pumped by the heart per minute, In other words, they receive about 21% of our cardiac output, okay, which is a major amount of how much blood our heart is pumping. Now, key with that statistic is that's going to be at rest. When we're in an exercising state, or when we have that fight or flight response active, that number is going to go way down because we're not going to be concerned with making urine, filtering our blood. We're going to be concerned with, fighting and flighting. So we'll be distributing more of that blood to our working skeletal muscle and our heart muscle. In our vessels lecture, where we did a bunch of coloring, there was a slide where we colored the aorta and its different parts along with some of the major branches. Two very small arteries that I had you color were the renal arteries, and I mentioned the fact that those were super important. They arise from our abdominal aorta. There's a left and a right. In this case, this would be a right renal artery. Just before entering the kidney, they actually fork, forming what we call segmental arteries. We can see the same picture essentially down here at the bottom, except now we've kind of focused on the arteries involved. Those segmental arteries project inward into the kidney and then branch, forming what we call interlobar arteries. Inter, remember, means between, so between the lobes are where these travel. Okay, remember, a lobe includes a pyramid and then a half of cortex, or excuse me, half a column on each side in the cortex. So that's where those interlobar arteries go. So they're traveling out to the outer part of the kidney. And from there, we form what are called arcuate arteries. And these are very small arteries at this point, and we're going to continue to get even smaller. So let me read through. Segmental arteries give rise to interlobar arteries that travel between each renal pyramid, where they can branch into arcuate arteries and what we call interlobular or cortical radiate arteries. The kind of newest edition of the textbook has kind of transitioned from calling it interlobular to cortical radiate. You'll notice down here at the bottom of the page, they have them listed in our kind of flow chart here as cortical radiate. They have them labeled in the picture that way. The previous edition, they kind of went with interlobular. I guess I understand interlobular. There's a lot of probably confusion there, so they are kind of transitioning away from it. But make sure you know both ways. These are arteries that pass more out into the cortex, and as they pass out into that cortex, they branch into a series of what we call afferent arterioles. And as it says here, or as previously discussed, well, I need to really kind of take that out because I've kind of changed the order of the lecture. I moved this slide up from kind of farther back in the lecture. But afferent arterioles turn into a mass of capillaries called a glomerulus. And this is all structure and stuff associated with a nephron. This is actually what a nephron looks like. We'll get into nephrons here more on the next page. But a glomerulus is this capillary network where we actually start filtering our blood and begin the processes of making urine. So we end up pulling a lot of fluid out of the body, or out of the blood, and collect it into our nephron, forming what's called filtrate. We wouldn't call it urine at this point, but that's the precursor to urine. What doesn't get pulled out of the blood exits that what we call renal corpuscle and what we call an efferent arteriole. Okay. So discussed previously, which we haven't, but into a spherical mass of capillaries called glomerulus, and then leaves the glomerular capsule as an efferent arteriole. The afferent arteriole also will pass near the distal convoluted tubule, and with it forms what's called a juxtaglomerular apparatus. So I'll kind of point that out here when we talk more about the nephrons in the next couple of slides. But this enables the nephron to monitor and stabilize its own performance and compensate for fluctuations in blood pressure. The efferent arteriole leads to a plexus of what we call peritubular capillaries, which are all these vessels that surround what we call tubule. They're shown here in kind of purple. Down at the bottom, surrounding what's called the loop of Henle, is a network of vessels called the vasa recta, which is all found down specifically in the renal medulla. These things will kind of make a lot more sense when we get to our slides here on the nephrons. Renal veins basically trace the same path, except it's in reverse, as what we just talked about with the arteries. So from the interlobular cortical radiate veins, to the arcuate, to the interlobar, to the segmental, and then they successfully merge and exit as a single renal vein. Usually we have one from each kidney that drains into the inferior vena cava. Now, as far as the picture goes here on the left, I'm not worried about it. It's really way too hard to identify different parts. But, I really do like the fact that, I've got this little flow chart here, and it's kind of a pun intended thing, because I think it is important to kind of be able to go in correct order from the renal arteries all the way back out to the renal veins. So, I'd put a star on that. Make sure next to cortical radiate arteries and cortical radiate veins, you put in parentheses what we called the interlobular arteries or interlobular veins. Okay, these would be the interlobular arteries. These would be interlobular veins. Figure on the right is a picture of an actual cadaver kidney, where essentially what's been done is a really cool chemical has been injected into the vessels that hardened up, and then they kind of, I don't know how they do it, but they essentially get rid of the the kidney tissue, and all that's left is that hardened blood vessel, to just really demonstrate just how crazy amount of vascularization there is within our kidneys. Basically every square centimeter, I would say, is loaded with some form of vessel, and just demonstrates, even though our kidneys are small, they receive a lot of blood flow and filter our blood as a result. Okay, let's talk about those nephrons I've been mentioning. All right, each kidney, as I mentioned earlier, has about 1 million of these functional units called nephrons. Two principal parts to a nephron exist: the renal corpuscle, which involves some of those things that we just talked about, where we filter our blood and form what's called filtrate or glomerular filtrate, kind of more sophisticatedly described. It's composed out of afferent arteriole, the glomerulus, and the efferent arteriole that we talked about on the previous page. That's what's pictured here at the bottom. And then the remainder of the nephron is this long, winding, crisscrossing, looping, what we call renal tubule, okay, which is going to process that filtered plasma and form it into urine. Okay, we'll get into the renal tubule and its parts here on the next page. For now, let's talk about the structure of a renal corpuscle. Okay. So I'll kind of bounce back and forth with the picture and the information at the top. First thing I want to talk about is this, what we call afferent arteriole. The afferent arteriole brings blood into the renal corpuscle, which, as I said previously, turns into, once inside, a mass of capillaries called the glomerulus. Now, in this picture, we can't really see the capillaries very well. There's not much red in here. See a lot of yellow, things that to me always look like little bugs. Okay. These little yellow cells are called podocytes, which are wrapping around the capillaries, okay? And here's a zoom in at one of those podocytes with their little leg-like extensions, each of which is called a pedicel. And they create a kind of barrier to prevent stuff from leaving the blood that shouldn't, okay? I'll get into all that here in a minute. But just know inside of this yellow, kind of creepy looking part of the picture, there are lots and lots of capillaries. Those capillaries are called glomerulus, okay, or glomerular capillaries, where we pull stuff out of the blood and create what's called filtrate. What doesn't leave the blood will exit via what's called an efferent arteriole. Okay, so let me read through here again. Afferent arteriole brings blood into the renal corpuscle, where it turns into a mass of capillaries called a glomerulus, which functions due to a large pressure gradient, meaning there's a lot of pressure inside of those capillaries, and this is due to having been branched from the aorta. It's not a direct branch, but it's a distant branch. Substances that are in our blood that are small enough to pass through the pores in the capillary walls are forced out into the capsule. Now the capsule includes two layers, a parietal layer and a visceral layer. And the parietal layer is just the layer of cells that forms the outside. Okay, so it encloses the entire structure. The visceral layer is made up of those podocytes that wrap around the capillaries. Between the two layers is the space called the capsular space, or you'll sometimes see it listed as a Bowman space, that captures that fluid that leaves the blood. Okay. And in doing so, it's then going to drain it out into the very beginning of our renal tubule, what we call the proximal convoluted tubule, or you see it just listed here as a proximal tubule, which is the first segment, like I said, of the renal tubule. Now, in order for stuff to leave the blood, it has to cross through what we call the filtration membrane. Okay, and that's what's pictured down at the bottom. Let's read through a little bit more, and then I'll kind of go back down to it. The glomerular Bowman's capsule is a two-layered capsule enclosing the glomerulus. A capsule is composed of an outside layer of simple squamous epithelium. That's this, what we call the parietal layer. The inner layer of the modified squamous epithelial cells called podocytes, shown down here, wrap around the capillaries that I've been talking about. Okay. Pedicels are these fine processes on projections of the podocytes that mesh with the adjacent podocytes, forming a dense network around the glomerular capillaries. So they kind of, it's like they're locking fingers, but notice there are little gaps in between those pedicels. Okay. It's not going to be completely tight, preventing anything from leaving the blood, but it's going to prevent the big stuff. Okay. Now, looking at this picture at the bottom, we show the structure of the filtration membrane and the three layers that make it up. We've kind of pulled out the endothelium of this capillary, and we've noticed and see here there are all these little tiny holes in it. Okay. We learned previously that there were three types of capillaries in the body. We learned that there were continuous, which were found in most places of the body. We learned that there were the sinusoids, which were like Swiss cheese. Then there were these, which were kind of in the middle. We called them fenestrated capillaries, that have these holes, pores, fenestrations, whatever you want to call them, that are pretty leaky. Okay? Quite a bit more leaky than your continuous, but the holes aren't quite as big as what we saw in our sinusoids. These holes are going to allow really small stuff to leave the blood, which includes like water, a lot of different ions, a lot of different waste products. What it's hopefully not going to allow through these holes would be your full-size blood cells, your platelets, your plasma proteins. And we want to keep those things in the blood. Should not be peeing out blood and that kind of stuff, because those cells and whatnot should not be able to pass through these little holes. Now, directly outside of that epithelium is its basement membrane, which, as it says here, prevents the filtration of larger proteins. And then the little gaps between those pedicels is occupied by another membrane, what's called the slit membrane, which prevents filtration of medium-sized proteins. So I always say it's kind of like having two layers of coffee filters that surround the holy capillaries, and then surrounding the entire structure are cells that wrap around with their little finger-like extensions. And so it's just a big barrier that prevents anything big from leaving the blood. Like I said, your red blood cells, your white blood cells, your platelets, and your plasma proteins. Okay, so when we form what's called filtrate and it collects out here in the capsular space, it's basically just like what we saw with plasma, the waste products, the majority of it's water, you got ions and other things. Some of those things are going to end up being completely lost from our body in our urine. Other things will actually return to the blood out in our renal tubule. Okay, like I said, we call it glomerular filtrate, or as I usually just call it, filtrate, the fluid that filters from the glomerular capillaries. As far as the pictures go, this is the one that I want you to know. I'm not going to make too much of it, so just highlight the afferent arteriole, the parietal layer of the capsule, the capsular space, the podocytes of the visceral layer, and then over here the efferent arteriole. Okay, now let's move on to our long winding hollow tube known as the renal tubule, where we process that filtrate, eventually forming what's called urine. Okay, renal tubules are winding hollow tubes that extend from the renal corpuscle to the end of the nephron, where it joins what's called a collecting duct that's shared in common with other nearby nephrons. So we'll talk about collecting ducts. You already had to write that out here in just a minute. Okay, collecting ducts finalize and eventually form the urine that drains eventually out of the kidneys down into the ureters. Okay, we can describe our renal tubules as the urine collecting and concentrating tube, and there are three regions or three parts to it. The proximal convoluted tubule, or as it says on said on the previous page, the proximal tubule, the loop of Henle, or nephron loop, as it's also known as, and then the distal convoluted tubule that you'll sometimes see is just listed as distal tubule. Now, the word convoluted that you see here a couple different points is just a fancy word for like a jumbled up situation, okay? Looking at our figures here at the bottom, we can see here's the proximal convoluted tubule. You can see it's kind of jumbled up, zigzagging, twisting. Kind of we see the same thing over here with the distal convoluted tubule. Okay, in between those is the loop of Henle. Now, what we're looking at down here at the bottom are the two different types of nephrons. I'll go ahead and talk about this part here first. The majority of our nephrons are called cortical nephrons, and that's because the majority of them is located out in the cortex. They make up about 85% of the nephrons. Now, they do have a loop of Henle that just barely dips down into the renal medulla, but not nearly as much as what we see here with what we call juxtamedullary nephrons, which have a very deep dipping loop of Henle that goes much deeper into the medulla, and it also is going to result in making a little bit more concentrated form of urine. Not that I'm going to get into this or that in this lecture. Okay, they're the ones that you see a very complicated set of blood vessels. That's what I had to write down here on the 2 slides ago, I guess. The vasa recta, shown here kind of periodically throughout the parts of the loop of Henle. Now we'll get into all that, but let's first talk about the proximal convoluted tubule, which, as I said, arises from the glomerular capsule. It's composed of simple cuboidal epithelium. Simple, remember, means this is one layer. Simple cuboidal means that the one layer of cells is cube-shaped. Inside, you have a lot of mitochondria, which is important because it gives them a lot of energy, which allows for them to perform a lot of what we call reabsorption and secretion. Reabsorption is where we pass the filtrate that we just formed back through the wall of the tubule and return it back to the bloodstream. And secretion is the opposite, where we push stuff from the blood through the wall and into the lumen to end up being part of what we call our urine. Now, if I go back to the previous page, we can see just a few of those cells of our proximal convoluted tubule. we see that those cells have little finger-like extensions. We learned about what we call microvilli back at the very beginning of the semester that increase their surface area. We call this layer of microvilli the brush border. And it's just like the brush border that we learned about with our small intestine that performed a lot of the absorption and secretion of our gastrointestinal tract. Okay. In this case, we're going to be pulling stuff from the tubule lumen through and into the bloodstream. That's what reabsorption is, and the opposite would be going the other way into the tubule for secretion. Okay. Each day, what we end up doing is pulling out about 45 gallons of filtrate from our blood. Think about that number. 45 gallons is a heck of a lot of filtrate. Obviously, we're not peeing out nearly that much, which means that we have to return like 99% of that filtered fluid. And a lot of that filtered fluid is returned right away in the proximal convoluted tubule. So it's kind of weird. We pull out a whole bunch of fluid from our blood and then we give it right back in our proximal convoluted tubule. Okay. That's just what happens. That's what our body does. Location of the proximal convoluted tubule is strictly out in the renal cortex, whereas the loop of Henle, as you can see, and I already kind of talked about, dips down into the medulla. Okay, it's a long U-shaped structure where there are kind of two halves to it, a descending limb and an ascending limb. Get to that here in a second. The cells of the loop of Henle can be simple squamous, which simple once again means a single layer. Squamous, the cells are flat and plate-like. Simple cuboidal, like what we just saw here, the PCT, or some are more tall, simple columnar. Okay, key here is that the cells in the loop almost entirely lack the microvilli, so they don't have that brush border like we just saw with the PCT. We can describe the limbs as ascending and descending. We can also describe them as whether they're thick or thin, and it's based on the width across the limb, and I'll just kind of explain that here. The descending limb is going to take that filtrate from the proximal convoluted tubule and dip it down into the medulla, and then we have a hairpin turn where we then travel back out into the cortex. We call that the ascending limb. Now looking over here on the right side of the page, we can kind of see it a little bit better. Looking at this side of the picture, the ascending limb is quite a bit more thick than right over here, and we kind of see the same thing a little bit down here, than the descending limb. The descending limb is predominantly made up of kind of thinner tube, whereas the ascending limb is quite a bit thicker. Okay, we can kind of see it a little bit better, the differences between the two sides. I'm not really going to get into it, but we'll just kind of explain it really quickly. Your thin segment is thin, which allows water to easily escape through the walls and then jump into these capillaries that are surrounding it. The thick segment is thick because it's got a lot of mitochondria. It is responsible for pumping out salt into the renal medulla. And they say actually if you're ever going to eat a kidney, some people do, cultures, not so much here in America, but they say that the middle part of a kidney tastes really salty, and that's actually because of what's taking place with the pumping of salts. Okay. So it's kind of crazy, but that's what's taking place. Okay, so kind of read through most of that, but I explained the rest of it. So I'll move on to the distal convoluted tubule, which is this segment here that is passing strictly out in the cortex, and we'll deliver that filtrate to the collecting duct. Okay, I'll get to the collecting duct here in a second. Let's talk about the juxtaglomerular apparatus, a portion of the distal convoluted tubule that brushes past the afferent arteriole, which helps to maintain the homeostasis of blood flow. Okay, I'm going to go to the next page where, sorry, I need to zoom out so I know where I'm at here. We got a full-sized nephron, not just a small one like what's at the bottom of those that page with those two. Notice right here, I'm going to draw a circle here with my cursor. The distal convoluted tubule is passing right by that afferent arteriole. Okay, and I say passing right by, they actually touch one another. Okay. What can take place is really cool, and I'm not going to really get into it, but there is communication that can exist between the cells of the distal convoluted tubule and the afferent arteriole. On your page, so go to that next page where you have the full-size nephron. Draw a circle just like I am right here and label that. Label that as what we call the juxtaglomerular apparatus. So, juxtaglomerular apparatus. If I go back to this page, I didn't talk about this segment of our figure, but it says it's the ascending limb. I don't know why, because it's not. It's the distal convoluted tubule. But here's that tubule passing right by that afferent arteriole. The cells literally touch one another. The cells within the distal convoluted tubule, called macula densa cells, can communicate with these smooth muscle juxtaglomerular cells of the afferent arteriole. Basically, what happens is, let's say we're not doing a good job of getting stuff back into the blood. Like I said, we form a whole bunch of filtrate a day, but we need to return most of that. Let's say we're going to end up losing way too much water from our body. So we're forming a lot of filtrate. Things are going really, really fast. We need to slow them down. These cells can tell these cells to like kink this hose, to kink this afferent arteriole to slow things down. And so it's kind of a communication thing that's something that's way above what I'm going to talk about in this class, but it's pretty cool. Okay. Now at this point, we've almost finalized the formation of the urine. The filtrate's going to flow out into what's called a collecting duct, where we finalize it and then eventually drain it out into our papillary ducts in the form of urine. Okay. Now a collecting duct, as it says, is formed by joining distal convoluted tubules of several nephrons. If we look at this picture or this picture here, we see these little branches kind of off to the side that are going nowhere. That's not what's actually taking place. They've just cut them off, but there would be an entire nephron connected in this direction, this direction, this direction. So a collecting duct shares itself with multiple nephrons, if that makes sense. Okay. And collecting duct cells are cuboidal with few microvilli. Within the medullary pyramids, they merge to form papillary ducts, drain into the minor calyces that we previously talked about, of the renal pelvis through the medullary papillae. Two types of cells are found in the collecting duct in the very end of the distal convoluted tubule. Principal cells that respond to the hormones aldosterone and antidiuretic hormone, which we've mentioned before. I won't really get into them anymore. But they help finalize the formation of the urine, and the intercalated cells that secrete hydrogen ions to help us control our pH. Okay, so that's the information. Let's go to the next page. So aside from the thing that I had you circle and label as the juxtaglomerular apparatus, here's what I want you to highlight. Highlight the proximal convoluted tubule here on the left, as well as the peritubular capillary. On the right side, highlight the renal corpuscle in the two parts, the capsule and the glomerulus, the efferent arteriole, the distal convoluted tubule, the afferent arteriole, the nephron loop, and it probably would be a good idea next to that in parentheses put loop of Henle. And then make sure you know the descending limb, the ascending limb, collecting duct, papillary duct, renal papilla, and minor calyx. And then it might not be a bad idea, go ahead and put a star around this box here. Make sure you can trace the flow of the fluid, so know that flow chart, pun intended. Okay, so as you can see here at the bottom of the page, at this point we've got urine, so we're ready to move on to the structures called ureters. So finally done talking about the kidneys. Moving on to our next organs, we're going to talk about the ureters and the bladder here on this page, and then we'll kind of focus more on the urethra, our final structure, on the last page. Okay, as we learned earlier, the renal pelvis is going to funnel that urine into a ureter. Ureters are muscular tubes pass posterior to the bladder and actually enter and fill it up from the bottom, from below. They exit each kidney at the renal hilum. We talked about that earlier. Course downward. They're also retroperitoneal organs. 3 layers of tissue form the wall of a ureter: inner mucosa, middle muscularis, outer adventitia. There's actually a lot of similarities between our ureters and the esophagus. Now, the esophagus, remember, was the tube that carried food down to our stomach. It was a muscular tube that was collapsible. We kind of see the same thing with our ureters. There were 3 layers to the majority of the esophagus. We see the same thing here. Both the esophagus and our ureters are lined with a mucous membrane. Okay, the mucosal layer here secretes mucus to protect the ureter tissue from the urine. Urine is slightly acidic, as we have kind of already mentioned. So the mucus helps, keep the wall of the ureter safe. The mucous membrane here has transitional epithelium. If we remember all the way back to the beginning of the semester, we learned that transitional epithelium is a fancy kind of epithelium, and that the cells can change their shape. So they can go from like cube shape to flattened plate-like squamous shape. And that allows the mucosa to kind of thin itself out, which increases the lumen of the esophagus just a little bit so the urine can flow more easily. There's also an underlying lamina layer, lamina propria layer of areolar connective tissue. Outside of that is the middle muscularis layer with longitudinal and circular layers of smooth muscle that force urine forward by peristalsis. Just like the peristalsis that we talked about in our digestive system pushes in this case, urine forward. It would actually allow you to push that urine down from your kidneys into the bladder, even if you were upside down, kind of like how we said we could swallow upside down. The outer layer is an adventitia layer consisting of areolar connective tissue, where we find nerves, blood vessels, and lymphatic vessels. From there, the urine is going to flow into the bladder. It is just a muscular sac on the floor of the pelvic cavity. Sits inferior to the peritoneum, like we show here in our picture. It's posterior to the pubic symphysis, which is that little piece of cartilage between our 2 hip bones. In men, it's located in front of the rectum. In females, it's located in front of the uterus. Okay. Inside, we've got a couple things to talk about. 2 openings associated with the ureters are the urethral openings. Okay, the word literally is in it, ureter. So that's an easy way to remember that those are the openings to the ureters. We've got 2 ureters, so there's 2 urethral openings. There's another opening that leads the urine out of the bladder, what we call the internal urethral orifice. The internal urethral orifice opens to the urethra, whereas the external urethral orifice leads urine out of the urethra. So don't confuse the internal with the external. Do not confuse the orifices with the sphincters. We'll kind of talk more about them on the next page. But the sphincters are muscle that control the act of peeing. Just like, the anal sphincters that we talked about. There's an internal, there's an external. We'll get into that here in just a little bit. Let's go back into the bladder, and we can see there's a triangular shaped area called the trizone drawn with dotted lines, because it's not actually lines there. but it's between those three openings, the two ureteral openings and the internal urethral orifice. The trigeminum is just this smooth surface triangular area on the bladder floor. Happens to be a fairly common site of bladder infection, just FYI. Just like our ureters, the bladder contains 3 layers of tissue to form its wall. An inner mucosal layer is a mucous membrane similar to that of ureters, except it's got rugae. Rugae, which are folds of the mucosa, permit expansion, kind of like the rugae that we learned about that which organ had? Your stomach. Okay, so there's actually some pretty similar situations with our stomach and our bladder. Both are kind of just holding tanks. Although our stomach does a lot of digestion as well, our bladder just kind of holds the urine. The middle layer of the bladder is a muscular layer called the detrusor muscle. It has a fancy name. It's actually 3 layers of smooth muscle, inner longitudinal, middle circular, and outer longitudinal. Around the opening to the urethra, so around the internal urethral orifice, the circular fibers form what's called that internal urethral sphincter, which, as you can see here in parentheses, is involuntarily controlled. So it's just like the internal anal sphincter. Remember, IN for internal, IN for involuntary. Easy way to remember that. Inferior to it is the external urethral sphincter, shown here, which is a modification of the deep muscles of the perineum. The perineum is our muscular floor of the muscular floor of our pelvic cavity. There's the word I'm looking for, pelvic. Notice here it's voluntarily controlled, just like the external anal sphincter was, or is. Most superficial coat on the posterior and inferior surfaces is what we call an adventitia, a layer of areolar connective tissue, continuous with the ureters. Over the superior surface of the bladder is serosa, a layer of visceral peritoneum. As far as the picture goes, make sure you know everything in it, with the exception of the hip bone. That's labeled. Everything else will be absolutely important and fair game to know for the exam. Now, this would be a picture of a female, and I can tell you because the urethra is really short compared to the male urethra, which, as we see here on this final page, is very long. Let's talk about that here on this page in greater detail. Okay, urine is a structure that transfers urine out of the body, a process we call micturition. So micturition is just a fancy word for peeing, not to be confused with mastication that we previously learned. Sounds similar, but mastication we know is chewing. Micturition is peeing, obviously 2 very different things. Our urethra is a tube that exits the bladder and drains urine out to what we call the external urethral orifice, which is the exterior opening of the body. In both males and females, it is the terminal portion of our urinary system, passage for discharging urine from the body. Here's a big difference. In men, it also discharges semen, so it's reproductive in function as well. So we'll talk about it again on Tuesday when we move on into our reproductive lecture. Male urethra extends from the internal urethral orifice to the exterior while passing through the prostate gland, through the deep muscles of the perineum, and then through the penis. So it's actually got 3 different distinctive regions. A prostatic urethra, okay, the intermediate or membranous urethra, and then the longest segment of it is called the spongy urethra, okay, because it passes through the spongy tissue of the penis. Down here at the bottom, it just lists the intermediate urethra, but it would be a good idea probably to put in parentheses the membranous urethra. Of the 3 regions, one of them is really kind of susceptible to issue. That would be this prostatic urethra. especially in older men, it is commonly more difficult to pee because prostate can enlarge and kind of pinch that prostatic urethra a little bit more closed. So you hear about older fellows not having ability to, empty their bladders completely. They can't maintain a steady stream. We'll talk about the prostate and what it does for men here on Tuesday because it's a reproductive organ. We'll get into all that next week. Total distance or total length of the urethra is about 20 centimeters or 8 inches. The wall consists of a deep mucosa and a superficial muscularis. The muscularis of the prostatic urethra is composed mostly of circular, smooth muscle fibers, superficial to lamina propria, and help form that internal urethral sphincter that I showed you and talked a little bit about on the previous page. Muscularis of the intermediate urethra consists of circularly arranged skeletal muscle fibers of the deep perineum, helping to form that external urethral sphincter. Several glands and other structures deliver their contents in the male urethra, and we'll discuss them in the next lecture. It includes the bladder, the seminal vesicles, the bulbourethral gland, as well as stuff coming from the testes and epididymis through the vas deferens. All those things will be discussed next week. Female urethra is only about 4 centimeters or 1.5 inches in length. External urethral orifice is located between the clitoris and the vaginal opening, and the vaginal opening leads to the vagina, which is the reproductive tube, whereas the urethra is strictly urinary in function. So 2 distinctive different structures. Female urethra consists of a deep mucosa, superficial muscularis. Mucosa is a membrane, a mucous membrane composed of epithelium and lamina propria. Muscularis consists of circularly arranged smooth muscle fibers and is continuous with that of the urinary bladder. Both men and women, the urethra is guarded by the 2 urethral sphincters that we've mentioned several times. An internal or involuntarily controlled urethral sphincter because it's made up of smooth muscle fibers. The external is made up of voluntarily controlled skeletal muscle fibers. Now, looking at the figures here at the bottom, these are both sagittally sectioned. So we're seeing half of the kind of lower portion of their body, or their torso, I should say. So down there in the pelvic area, we can see both men and women have some similarities, but there's quite a bit of differences. We're going to see these pictures again on Tuesday, where we're going to add a lot to it. We'll be talking about all the reproductive system structures. Only a few of them are labeled here in this picture. Kind of the same thing. We've got a few things labeled like the uterus, the vagina, but like the fallopian tubes, the ovaries aren't labeled, nor is, any of the external genitalia. So I'm going to have you just wait because, we'll highlight it now. We'll highlight it again. Might as well just highlight it one time. I'm not going to have, you guys have to worry too much about, knowing the picture 2 different times because, we'll just worry about what on Tuesday. Go ahead, though, and, put a big star on this box. I think it's important to know the differences between the male and the female when it comes to the urethra. 5 times longer in men than it is in women. Divided into 3 segments in males, but only 1 short tube in females. And it's a common duct for urinary and reproductive systems in men, only urinary function in women. All right, any questions?